Let us begin with a prayer from the book of Psalms. Lord, you formed my innermost being. You knit me in my mother's womb. Behind and before, you encircle me and rest your hand upon me. Wonderful are your works. And Lord, bestow your grace on us to be steadfast in nurturing life from its entering into this world to its leaving it. As Sister Paula taught us in her life, guide us always to be both compassionate and resolute. As we repeat her words of supplication, Lord, we come to do your will. Amen. So thank you all again for joining us today for Dr. George Delgado's presentation regarding abortion pill reversal, or APR. Dr. Delgado received his medical degree from UC Davis and is board certified in family medicine and in hospice and palliative medicine, and is a board member of the American Association of Pro-Life Obstetricians and Gynecologists. He is a regular guest on EWTN's Catholic Answers Live and is a guest contributor to the Charlotte Steno Institute. Dr. Delgado is president of the Steno Institute, which advances research, education, and awareness in abortion pill reversal. As a pioneer in APR, he established the Abortion Pill Reversal Network. He has authored and co-authored numerous articles in peer-reviewed medical journals, including Abortion Pill Reversal and mifepristone abortion. Dr. Delgado has received numerous awards, including ones from Walk for Life, Heartbeat International, Solidarity Health Share. It is a pleasure to welcome Dr. George Delgado.
Thank you very much for that kind introduction, and welcome to all of you. I'm glad you've had a chance to join us today as we explore the world of abortion pill reversal, giving women a second chance at choice. It's a very exciting topic for me. It's a very timely topic because of the increasing numbers of medical abortions in our country, now about 50% of all abortions. So those of you who work in pregnancy help centers, you'll be seeing women who are requesting a second chance of choice, whether you know it or like it or not. So it's better to be prepared, know how to help them, and be in a position to offer concrete help to them to be able to help them get progesterone so they can reverse their medical abortions. So this is going to be an update on a second chance at choice because it may not be too late to save a life. And I want to just state that I do not have any financial disclosures, no conflicts of interest. The three main points I want you to take home are that mifepristone reversal is safe, it's effective, and women who are given the opportunity to reverse the effects of mifepristone are very, very grateful. Let's go over a little bit of the terminology because it might be a bit confusing for some of you. Mifepristone is also known as RU46. I'll explain that in a little bit, why it's known by that also. The brand name is Mifeprix. In Canada, it's known as mifepristone. In Canada, the two drugs, mifepristone and misoprostol, come together in the same package, in the same container. In Europe, it's known as mifegyne. On the Planned Parenthood website, you might see pill abortion. You also might see the term medical abortion, which is the one that I tend to use. It's also called medical induced abortion. There also is a product called Korlym, which is mifepristone, but in 300 milligram tablets, as opposed to the 200 milligram tablets that are used for abortion. Korlym is approved by the FDA for treating a condition called Cushing's syndrome. And other medications are not useful, then the Korlym can be used. But they brand it differently in a different size drug so that it's not confused with the Mifeprex, or it's used for medical abortion. So the progesterone receptor was discovered by Dr. Aitin-Emile Ballou at the University of Paris in 1970. Dr. Ballou was quoted as saying, the receptors are like a keyhole and we were trying to produce a false key. So this is a really important point that I'm going to come back to in just a minute. Dr. Ballou served as a consultant to Roussel Uclaf, the company that developed mifepristone. The reason it was called RU46 was because many companies will develop compounds that never make it to the market. In fact, only about 25% probably of new drugs make it to the market. So they often don't take the time or bother with giving the drug a proper name. They will just give it a developmental label. And rusoluklev was no different. They would just number their compounds in the order that they were discovered. So the mifepristone was the 38,486th compound that they had discovered. So they simply called it RU486 for short. And that's how we got that name. Because this was such a notorious drug in its development, we knew about it many years before it got a proper name. Although the progesterone receptor was, and mifepristone was developed only in 1970, it was very quick in 1981 that human trials were started. So this drug was really moved very quickly through the pipeline. And in 1988, only 8 years later, France approved the sale of mifegyne in France. Now, the owner of rusoluklev did not want to market mifepristone, and because of pro-life pressures and threats of boycotts, the rusoluklev CEO decided to stop sales. However, the French government forced rusoluklev to distribute mifepristone in France. Rusoluklev wanted to get rid of mifepristone because, as you can imagine, they considered it to be a radioactive drug and they saw lawsuits on the horizon. So rusoluklev granted the United States rights to a group called the Population Council, which eventually granted them to Danko Laboratories, a single product corporation. A similar strategy was enacted in Europe. Why a single product corporation? Well, because they figured that if the corporation only had one product, the mifepristone, if a lawsuit took down the corporation, it wouldn't be as big of a hit as if a lawsuit came against a huge pharmaceutical like rusoluklev and took that whole corporation down. Corporate history is very interesting because you can see that after mergers and acquisitions, the corporate descendant of rusoluklev is Sanofi, which is still around today. If we look in the other direction, we can see that Hoche AG, which owned rusoluklev, was founded in 1800s in Germany. In 1916, Hoche AG was one of the corporate constituents of IG Farben. IG Farben managers were tried at Nuremberg for exploitation and experimentation of prisoners in World War II concentration camps. And an IG Farben subsidiary distributed Zyklon B, the cyanide gas that was used to kill more than 1 million concentration camp prisoners. So you can see that there's a corporate trail of death and destruction here. Before we go further, I want to make sure that we all understand the difference between the abortion pill on one hand and the morning after pill on the other hand. I've been surprised because even physicians to whom I've spoken about this have gotten the two confused. Well, the morning after pill, also known as emergency contraception, is designed to be taken within 72 hours, except for Ella or ulipristal, of intercourse to, quote, prevent pregnancy. Now, these drugs are probably abortifacient most of the time. We don't have time to get into that. But the fact of the matter is that the women who take emergency, quote, emergency contraception, they don't know they're pregnant and they take them with the intent of preventing a pregnancy. On the other hand, mifepristone is approved for use in pregnancy up to 10 weeks pregnancy in the United States. It's a deliberate attempt to abort a known pregnancy. The woman knows she's pregnant and tries to abort her baby. There's some important bottom lines. First, mifepristone and other medical abortions are equivalent to traditional surgical abortions. There are two end results that are the same. The mother is victimized by the medical abortion complex and the preborn baby is killed. However, the reason we're here today gathered is that there's one key difference in that medical abortion is now reversible. On the other hand, surgical abortion, once the instrument enters the uterus, there's no turning back. The preborn baby has been killed. Remember when I said Dr. Ballou talked about false keys? Well, I want to now go into more detail about these false keys and really how hormones work. Because progesterone is the hormone of pregnancy. That's why it's called progesterone, progestation. Without progesterone, every pregnancy would end in a miscarriage. In fact, we know that women who have very low progesterone levels, they are what we call habitual miscarriers. They continue to miscarry time after time unless they're supplemented with progesterone. Well, how do these hormones like progesterone work? One way to give an analogy is to talk about the hormone being like a key. And you know that a key fits into the lock. The lock would be the hormone receptor where the hormone lands. So a key goes into the lock, you turn the key, the lock turns, and a door opens. That door opening is what I call the hormone effect, the good things that the hormone does in the body. And in a few minutes, I'll tell you about the good things that progesterone does in the body. Well, I'm sure all of you have had the experience one time or another of putting a key into a lock where the key fit into the lock, but the lock did not turn. Now, when that happens, the door stays closed. So essentially, that false key is blocking the lock. The analogy then is the mifepristone is blocking the receptor. So the false key, the mifepristone, blocks the lock so that the good key, the progesterone, can't get into the lock. If the progesterone can't get into the lock, the door never opens. That's how mifepristone works, by being a false key, by blocking receptors, not allowing progesterone to latch onto those receptors. Now, fortunately, it's a dynamic process, and the mifepristone goes on and off the receptor. When the mifepristone comes off the receptor, that's the opportunity for progesterone to jump onto the receptor and to cause the good hormone effect. So our theory in abortion pill reversal is that we give supplemental progesterone, raising the level of the progesterone, the good guy keys, so that there are more of the good guy keys lined up in front of that lock. So when the false key comes out of the lock, there's a higher probability that the good guy key progesterone will go into that lock, turn the lock, and the door will open and will have hormone effects. And we sustain those elevated levels of progesterone until the mifepristone is washed out. So now let's talk about some of the actions of progesterone. What does progesterone do? Why is it progestational? Well, first of all, even before a woman is pregnant, the progesterone prepares the lining of the uterus for implantation of a human embryo. It makes the lining of the uterus, also known as the endometrium, thick and luxuriant so that the 7 to 10-day-old embryo can implant there successfully. It also promotes the development of the maternal part of the placenta called the decidua basalis. And that maternal part of the placenta, it's a very, very, very thin membrane, but it's so important in keeping the rest of the placenta attached to the uterine wall, because that good attachment is necessary for the exchange of water, nutrients, and for waste products to go from the baby to the mother. So that placenta is the lifeline. That decidua basalis is the glue that keeps that lifeline firmly adhered to the uterus. So progesterone is what keeps that glue sticking the placenta to the wall of the uterus. Progesterone also inhibits contractions of the uterine muscle. The uterus is essentially a sac that's an expandable sac, and it's a sac made out of muscle. So in order for that muscle to expand and allow the baby to grow inside of it, it cannot be contracting. It has to be nice and relaxed. The progesterone is a muscle relaxant, so it keeps that muscle nice and soft and relaxed. It also does something to the cervix. The cervix is the opening of the uterus. The progesterone keeps the cervix closed like a biologic valve so that the outside world has no communication with the inside world. Progesterone also promotes the growth and development of milk-producing cells in the breast. That's very, very important. At the same time, though, interestingly, and this is a very elegant design, the progesterone inhibits milk production because, of course, the mother doesn't need milk produced during the pregnancy, only after the pregnancy. Progesterone does all of that. Well, what does mifepristone do by blocking progesterone? Well, first of all, it disrupts the lining of the uterus. Secondly, it causes separation of the maternal part of the placenta from the embryonic part of the placenta. The placenta separates, comes off of the wall of the uterus. What does that do? It cuts off the lifeline. And when the lifeline is cut off, the preborn embryo dies. So this is the action that causes the death of the preborn embryo. Mifepristone also leads to uterine contractions, because remember I told you that progesterone relaxes the uterus. Well, if you're blocking the actions of the relaxation of progesterone, well, then you will have contractions and the uterus will start to get twitchy. The cervix also starts to soften and open. And finally, it stops the development of breast cells, which is under the direction of progesterone, and it leaves those cells in a very cancer vulnerable state. In the United States, mifepristone currently accounts for about 50% of all abortions. So let's say 400,000 to 550,000 abortion a year. So this is going up and up and up. In some countries like Scotland, mifepristone abortions account for 75 to 80% of all abortions. In the US, the FDA has approved the following protocol. The mifepristone abortion is approved up to 70 days after the last menstrual period. That is 10 weeks of pregnancy. These days, I am seeing abortionists pushing that up to 11 or 12 weeks. On the first day, they give mifepristone 200 milligrams orally. And usually now 24 to 48 hours later, they're instructed to take misoprostol 800 micrograms between the tongue and cheek. Usually what they'll do is they'll get 200 microgram pills, which is the size of pills that are made, and they're told to take 4 of them under the tongue or between the cheek and gum. The misoprostol causes the uterus to contract. And that's why there are 2 drugs, because mifepristone is very effective at killing the embryo or the fetus. Survival is up to 25% at best, according to our calculations. However, up to 40% of the time, the uterus will not completely empty of the remains of the preborn baby. That's the reason why they give the second drug, the misoprostol, to cause the uterus to contract and to expel any remaining contents. So we have a window of opportunity between the 2 drugs. If the woman has taken mifepristone but has not taken the second drug, the misoprostol, she can choose to reverse the mifepristone abortion because the progesterone can reverse the effects of the mifepristone. However, we currently do not have an antidote for the misoprostol, the second drug. Well, I got it started on this back in 2009. We started collecting a few cases, and in 2012, we published this first ever article in the peer-reviewed medical literature detailing 6 cases of attempts at abortion pill reversal. Since then, we have documented more than 2,500 babies born after successful reversals of their mother's medical abortion. So we're very excited about that. These are just the ones we in Heartbeat International have been able to track. Now, I want to talk about a control group now, because studies up until now have been observational case series, except for one study I'll talk about in a second. And historical control groups are in the literature. What do I mean by a control group? That means what would happen if a woman took mifepristone and did nothing at all, did not take progesterone, did not do anything, and just waited to see if the baby would survive. And we've been able to come up with that rate up to 25% would survive. And as you'll see going forward, placebo groups in studies, and that's a group where a woman took mifepristone and nothing was done, would ethically not be appropriate or not be acceptable to us because it would be dooming those babies to death. In 2017, Dr. Mary Davenport, I, and others published this article in a peer-reviewed medical journal looking at embryo survival after mifepristone. This is how we established our control rate of what would happen if a woman took mifepristone and nothing else was done. It's important to remember that terminology, if you hear people talking about something called incomplete abortion, all that means is that the uterine contents were not completely emptied. Incomplete abortion does not imply that the embryo survived, that the baby's still alive. And the incomplete abortion rate is 20 to 40%. That is when contents are still in the uterus. But actual embryo survival is only up to 25%. The reason I'm emphasizing this is because those people who oppose abortion pill reversal will sometimes misrepresent facts and say that, well, if the mother does nothing at all, 40% of the time, the baby is going to survive. That's not true at all. Baby will only survive up to 25% of the time. Up to 40% of the time, the uterus will not completely empty. In 2018, we published a large case series of over 260 successful mifepristone reversals using progesterone. This was also published in a peer-reviewed journal. And in this study, our reversal rates, our success rates with our high-dose oral protocol of progesterone was 68%. 68% of the time, the woman was able to carry her baby to term. And with the injection protocol, 64%. If you looked at all the groups who got any dose of progesterone, even just a single dose, then the success rates were 48%, which is still very good. So our survival comparison, just sort of the bottom line for everybody, if no treatment is offered, the embryo might survive up to 25% of the time. With our best treatments, the baby survives 64 to 68% of the time. So much better odds if the woman gets progesterone. Women often ask about birth defects and other complications of abortion pill reversal. We're very happy to report that in our study, the birth defect rate was no greater than the general population. That means that mifepristone and progesterone did not cause birth defects. And interestingly, the preterm delivery rate was actually lower than the general population, 2.7% versus 10%. So that's just an added bonus. In 2014, the American College of Obstetricians and Gynecologists came out with a practice bulletin saying that there's no proof of birth defects with mifepristone. So we're very happy when someone who's been opposing us on all fronts actually agrees with us on a point. They updated this just last year in October. And again, they said in their practice bulletin that there's no proof of birth defects if a baby's exposed to mifepristone, RU46, and survives. How about progesterone safety? In 1999, the US FDA did a review of the literature and concluded that there's no risk of birth defects, including something called hypospadias in women who take progesterone or 17-hydroxyprogesterone while they're during their pregnancy. So we're very comfortable, and progesterone has been used in pregnancy for over 50 years, so everyone's very comfortable with it. Well, we have received a lot of pushback from mainline medicine, especially the medical abortion complex. And one of the main players in that medical abortion complex, Dr. Mitchell Crennan, designed a study that he said would disprove APR. He canceled the study saying that he had safety concerns. Well, let's look at that study that even though he canceled it, it still got published in the very prestigious journal called Obstetrics and Gynecology. In the medical area, it's known as, quote, the Green Journal. It was a randomized controlled trial, double-blind, placebo-controlled, and there were two arms of placebo and a high-dose progesterone arms. In one way, this was a very unethical study, and I'll talk about that in a second. And in many other ways, it was a very well-designed study. It was well-designed because it was double-blinded. That means that the patients did not know if they were getting progesterone or a placebo, and the doctors who were taking care of them did not know what they were getting either. It was placebo-controlled, and it had a placebo, and it was a randomized trial in that the women who entered the study had no choice into which group they would land. A computer generated a random distribution. And both groups got mifepristone, one group got placebo, and the other one got progesterone. Now, Dr. Crennan did a pre-trial power analysis. This is a way of trying to estimate how many subjects you'll need in a trial. We're very happy that he utilized Dr. Davenport's figure for placebo, the historic control rate of 25% survival, if nothing is done, like we discussed earlier. And he also used our published reversal rate of 68% with the high-dose oral progesterone protocol. These were the figures he used to calculate his numbers. And we quote Dr. Crennan here. He said in his article, we estimated a 68% continuing pregnancy rate with oral progesterone treatment based on the report using the same dosing after mifepristone administration. And so the footnote there is to my article. So I'm very glad that Dr. Crennan cited my research. Now, after he did all of his analysis, he estimated that 20 patients would be needed in each group, 20 in the placebo group, 20 in the progesterone group. Of course, 20 plus 20 is 40. And it's very interesting to me that in his plan, only 40 patients were to be enrolled. That left no margin for dropout. And in most studies, if you think you're going to need 40 patients, usually recruit extras, let's say 50 or 60, counting on patients moving out of the area or stopping the study, or for whatever reason, being lost to follow-up. So since he only intended to recruit 40 patients, the actual number needed to produce statistically significant results, I'm wondering if his intentions truly were to conduct a serious study or if it was just to sabotage APR. But let's look at the results. If we look at the so-called intention to treat analysis, and by the way, the study was stopped short after 12 patients were admitted to the study, and I'm going to go into that in a second, why that happened. But the ones who did finish, there were 6 in the progesterone group, 6 in the placebo group. 4 out of the 6 in the progesterone group continued their pregnancies at 2 weeks, while only 2 out of 6 continued their pregnancies at 2 weeks. So you look at these numbers are very similar to the numbers I talked to you about before. Our 68 success rate with high-dose oral progesterone, which is what he used in his study, and the 25% placebo survival rate if nothing else is done. So you can see that Dr. Crennan's results actually support what we're doing. There were 2 that exited the study early. And if we exclude those 2 patients, then we're down to 10 patients, 5 in each group. 80% of those in the progesterone group had continued pregnancies at 2 weeks, and 40% in the placebo group had continued pregnancies at 2 weeks. Dr. Crennan also concluded that patients who received high-dose oral progesterone did not have side effects that were different from the placebo group. So in other words, the safety and tolerability was definitely there. Now let's look at why he stopped the study. So 3 out of 12 patients experienced very heavy bleeding, according to Dr. Crennan, resulting in ambulance transport to the emergency department. This rate was higher than the previous published rate of 0.6% of patients to emergency department visits. So because of that, he stopped the study. However, if you look at those 3, the one in the progesterone group who called the ambulance and went to the emergency department required no intervention, i.e. did not need to be in the emergency department. She simply panicked because she was bleeding. So she had what we call a failed reversal and then therefore completed her abortion. So she did not require any treatment and she didn't need to be in the emergency department. 2 patients, the other 2 required suction aspiration, that is a surgical abortion. Both of those were in the placebo group, that is, they did not get progesterone. There was 1 patient who required a blood transfusion. That patient was also in the placebo group, did not get progesterone. Therefore, the conclusion really is that it was the placebo group, not the progesterone therapy, that was unsafe. Mifepristone alone for abortion was unsafe in this study, and attempting reversal was not proven to be unsafe. Now let's look at other charges that have been leveled against us and what the support that we have, what I call the 3 pillars of support. First of all, there's biologic logic. We know that the mechanism of action of mifepristone, what it is, and what the mechanism of action of progesterone is, they compete for the same receptor like I described before with the lock and key analogy. And we know that in any kind of biologic system, if you raise the concentration of one of the molecules that's competing for a receptor, that one's going to win the race. And so you'll have more of that effect. So it makes biologic sense that if we raise the levels of progesterone by supplementing progesterone, it will win the race to the receptor. And we know that mifepristone was studied as an abortifacient precisely because it blocks progesterone. That's the reason they studied it, for no reason other than that. So that blocking the progesterone receptor is critical to it. And we know that increasing progesterone levels at the receptor should outcompete it. Next, we have an animal model. Basic science studies were conducted in Japan on rats that demonstrated that two groups of pregnant rats, that if one group was given mifepristone only, that group would abort all of its pups. If a group was given mifepristone and progesterone, there would either be far fewer abortions or no abortions at all in that group, depending on the concentrations. And we know that the changes when they looked under the microscope in the uteri were different in the groups that got mifepristone only compared to the ones that got mifepristone and progesterone. So in this animal model, progesterone definitely reversed the effects of mifepristone. Finally, our data, of course, with now over 2,500 women having successful reversals. And in our retrospective analysis, the success rate of 64 to 68% with our best protocols is far better than a 25% survival rate if nothing is done. Now, do people change their minds? Well, our opponents say that women who embark on medical abortions rarely, if ever, change their minds. However, even their commonly quoted studies suggest that 10% have ambivalence or second thoughts. Other studies that follow patients longitudinally suggest much higher rates. For example, studies done by Coleman and others. There was a recent study published in this peer-reviewed journal that looked at about 10 years of adverse events reporting to the FDA with mifepristone abortion. Now, I want to look at a subgroup of here. 452 cases were reported of women with ongoing pregnancies. And I want to point out that this whole reporting system is a passive reporting system. So it has to be the woman or the doctor gets on the computer or gets on the phone and tells the FDA about this. The FDA isn't out hunting for adverse reactions. Nonetheless, there were 452 patients who reported they had ongoing pregnancies after taking mifepristone with or without misoprostol. So these were 452, quote, failed abortions. Now, 102 of those, or 22%, chose to keep their babies and continue the pregnancies. 22%, that's much higher than what our opponents say, which is that it rarely, if ever, happens that a woman will change her mind. But these are concrete situations where women had to make that second choice, whether to abort or not abort, and 22% of them decided to not abort. So you can see here that when women are given that concrete opportunity, a high percentage of them will seek to choose to continue their pregnancies. So to conclude this part of the talk, mifepristone reversal using progesterone is safe and effective. We have 64 to 68% reversal rates with our best protocols. And these are the protocols: the high-dose oral progesterone protocol, the intramuscular injection of progesterone, perhaps a high-dose vaginal protocol. I put a question mark here because we have limited success data, and maybe even doing a combination of vaginal and oral. How do women get help? Well, usually they go online, social media, the internet, whatever, and they find the website abortionpillreversal.com. They read about it, they want to continue, they call the hotline. Here's the Abortion Pill Reversal homepage. You can see that it's also available in Spanish, and there's a chat function that's very useful to women. Reversing down under, Abortion Pill Reversal has spread internationally. We helped spawn a regional network called Australian Mifepristone Reversal. And in Russia, Dr. Alexei Fokin, on his own, translated my website into Russian and has been doing abortion pill reversal now for several years. So we've been having some communication with him. We plan to do more coordination with him. And Europe, people in Switzerland are interested in having a network there. I have made a visit to Switzerland in the last few years, and I'm hoping that that will develop. Krista Brown of Abortion Pill Reversal Heartbeat International traveled to Ireland last year. Irish physicians and others, including Dr. Phil Boyle, are hoping to create an Irish network. They have been unfortunately slowed by the government's unwillingness to accept abortion pill reversal. In the United States and around the world, we have more than 1,000 abortion pill reversal doctors. We want to get more doctors, nurse practitioners, midwives, and PAs to join the network. This is a paradigm of how a pregnancy help center can be involved. An APR patient client calls the APR hotline. The APR hotline then connects her with a pregnancy resource center in her area. If that pregnancy help center is medical, then she can get all her treatment directly through them. If it's not medical, then she can get a treatment through a local doctor or other medical practitioner and get all the important supportive counseling, care, follow-up, and mentoring from the Pregnancy Help Center. Resources we have: Option Line hotline is staffed 24/7. The calls are then routed to the APR nurses. We have consent forms, support follow-up as needed, model standing orders, model policies and procedures, the actual protocols, advice available from the APR staff. and I'm available to help doctors who have any questions. Now we've looked at all the numbers. Let's look at some of the faces behind the numbers. And I'm going to connect to Becky's story here.
I discovered I was pregnant for the second time when I was just about 19 years old. I had had my first child at 18 years old, so the thought of having two children at 19 years old led me to believe that I needed to have an abortion with my second child. I visited an abortion clinic. I wasn't really told what was going to be happening to my body, wasn't allowed to see my baby on a monitor. I was basically told that my chemical abortion was going to be quick, convenient, easy to hide, all things that I needed. And I took the first RU486 pill. As I sat outside of a Planned Parenthood clinic, literally after just taking the abortion pill, I immediately felt regret and like I needed to try to stop what I just started. I searched on my phone and found abortionpillreversal.com. They had a hotline number that advised anyone who had wanted to reverse the abortion pill, who had recently taken it, to call. After I called the hotline, a nurse answered named Debbie, and she basically told me that there was still hope for me and my baby, but that I just needed to get progesterone into my body and continue with injections of progesterone for several weeks following the abortion pill. Planned Parenthood told me that this likely would not work and my child could very well be deformed. These words replayed in my head for the rest of my pregnancy. I was very scared, but after I saw my son on the ultrasound and heard his heartbeat, I was filled with hope and encouragement, and I just knew that God had intervened and that I still had a chance to save my son, and I was just extremely happy and grateful. I look at Zechariah and I am just so thankful. I feel blessed that he's here because I know that it wasn't likely that he would be, that I had tried to abort him. I just look at him and I could not imagine my life without him. What I like most about being a mom is coming home to my kids. They're always so excited to see me. It's mommy, mommy, and that makes you feel so good. And just looking at them, I would never give up. They're the reason I go to school, the reason I go to work. I just have so much to live for, and I love that. Abortion is not a magic eraser. It's a permanent solution to a temporary problem. And raising children, being a mom, no matter how young you are, no matter the difficulties you're going through in life, is still a blessing. And for anyone who's considering reversing their abortion, I would encourage you, and I would be happy to support you and walk with you and talk to you and give you the encouragement that you're going to need on that journey. I've known many women that have regretted their abortions, but I've never known one that has regretted choosing life for their child, because you don't. You love being a mom and you love those children once they're here.
So you can see that abortion pill reversal is safe, effective, and women who have the opportunity to utilize abortion pill reversal are very, very grateful. Now, where we are now with Steno Institute in 2018, the abortion pill reversal network was passed along from my local nonprofit organization, Culture of Life Family Services, onto Heartbeat International, because we needed a broader based organization to continue to move it into the future and to expand it. And they've done an absolutely wonderful job. At that time, Heartbeat International felt that they wanted the medical protocols and research and education around that to stay with me. So I started the Steno Institute, a nonprofit corporation whose aim is to increase awareness, education, and research around abortion pill reversal. And that started back in 2018. We've been raising money to conduct a very large randomized controlled trial that we hope to launch sometime in the future that will compare different progesterone protocols. Why do we need a study like this? Well, because we've been criticized by people like Planned Parenthood, ACOG, ACLU of not having enough scientific data to support what we're doing, what we're recommending. Doctors need to feel more comfortable in recommending abortion pill reversal to their patients. More people need to be aware of abortion pill reversal. With better studies out there, awareness will increase. And policymakers and lawmakers who want to pass laws requiring the information about abortion pill reversal to be given at abortion centers need to have a better scientific basis, because every time they pass a law, they get sued by the ACLU, Planned Parenthood, and all the rest. So it's very, very important that we expand our scientific knowledge and understanding, not to mention to be able to finally develop these protocols so that we can offer women the very finest, best chance of success with the lowest chance of any complications or side effects. Our website is stenoinstitute.org if you're interested in finding out more about it. If you're interested in joining the Abortion Pill Reversal Network of pregnancy health centers or doctors or other medical practitioners, then go to abortionpillreversal.com. We will now have time for some questions.
So if anyone has any questions for Dr. Delgado, by the way, thank you, Dr. Delgado, so much for your presentation. So if you have a question, please unmute yourself and ask your question.
Dr. Delgado, the 25% survival rate, is that in women who take the first drug but do not take the second drug?
That's correct. The 25% survival is women who only took the first drug, the mifepristone, and did not take the second drug, misoprostol. So that's why we use that as a comparison group, because the women we treat for abortion pill reversal take mifepristone, the first drug, don't take the second drug, misoprostol, but then we give them progesterone. So we compare them to the group that only takes the first drug but does nothing else.
Have there been successful reversals when people have taken both drugs?
Yes, there have been.
Dr. Delgado, with the increase in abortion pill reversal nationwide, are you seeing other abortion providers move to other drugs like methotrexate to be used for the medical abortion?
We have been aware of a number of cases of doctors using methotrexate for medical abortion. It has more side effects, and it probably doesn't work as effectively at causing the abortion. So, and it's not FDA approved for that. So those doctors are going a little bit out on a limb. Fortunately, we do have a protocol to help reverse that, the methotrexate. However, methotrexate can cause birth defects, so that has to be carefully explained to the women. The other thing we have been seeing, and we've seen in the medical literature, and we don't know if it's to thwart our attempts or if it's for some other reason, but we have seen that there are studies, and sometimes women get the mifepristone and the misoprostol, they take it together. Now, the studies, I guess fortunately for us, show that when they are taken together, they are not as effective at emptying the uterus as compared to if you wait 24 to 48 hours to take the misoprostol. And the reason is that misoprostol's receptors are primed by the mifepristone. They work better. And so so taking the two drugs together as an attempt to thwart abortion pill reversal possibilities would lead to an increased rate of incomplete abortion.
Dr. Delgado, I know that there's an emergency regulation that allows the abortion pill to go through the mail. Do you know or have any thoughts about whether the FDA will approve that as a regular law? I'm not sure what you call it.
Sure, if they'll make that permanent. Yes, so right now the so-called REMS safeguards have been suspended. The REMS safeguards were installed because for many reasons, but for one, that mifepristone was pretty much rushed through development, rushed through the regulatory process. They did all sorts of unusual things to approve it, but they did capitulate to those who felt they were not doing the right thing, and they instituted these REMS. And some of the REMS are that they track side effects and adverse reactions, like we discussed. Another one is that the woman has to take the mifepristone in the presence of a healthcare practitioner in a clinic. So using the pretext of the COVID-19 pandemic, they said that, well, we're going to suspend this and the women can get it through the mail, can get it all sorts of other ways. The abortion proponents are pushing very vigorously to have the REMS guidelines suspended permanently so that they don't have to follow any of that. Right now, with the current climate in the FDA and the current administration, I think it's probably at least 50% likely that they will be made permanent, unfortunately. And women will suffer. Of course, we know that their embryos and their fetuses are suffering death, but women are going to suffer even more because they may not get an ultrasound before taking the mifepristone. They may have tubal pregnancies and be unaware of it. They may be Rh negative and not be aware of it, in which case their blood might be sensitized during the abortion, and future pregnancies could be harmed. So we can see there's a lot of harm, not to mention the possibility of coercion, because when you do the mail order thing, you don't know who's getting it. It might be a boyfriend who's getting the mifepristone in the mail and then secretly gives it to his pregnant girlfriend, or a man giving it to his pregnant wife, whatever the case may be. But you don't know whose hands that will get into, or maybe a grandmother orders it and then gives it to her grandchild who's pregnant. So all sorts of abuse potential is there with not having these guidelines.
Dr. Delgado, there's a chat from Kay Brown. Do you foresee ACOG giving full support in the future?
To abortion pill reversal?
I think that's the question.
Yeah, okay. Well, I don't see ACOG ever giving full support to abortion pill reversal, because ACOG in some of its statements has blatantly stated that it is an advocacy organization that advocates for the promotion of abortion. And of course, they use the code term reproductive rights. So ACOG is firmly pro-abortion. They're not neutral by any means. And when you support abortion pill reversal, what happens? What's the reason why they're so against it? Well, first of all, you acknowledge that some women change their mind and choose abortion pill reversal. Otherwise, we wouldn't have it. And if there are some women who change their minds about their medical abortions, then that puts a big question mark on the narrative that abortion is a great good for women. Because if it were such a great universal good, why would anybody change your mind after starting a medical abortion? So you can see why ideologically ACOG is so against this. What I would foresee is that as we get more data and firm scientific evidence published, and they conclude objectively that it's safe and effective, I think they will be more open-minded and they will be less judgmental. They probably will be neutral at best, but will not wholeheartedly support it.
If you don't mind, I have another question about the methotrexate versus the mifepristone. Will we know if we get a client coming in what they will have taken? Will they know if they took the methotrexate or mifepristone?
That's a good question, and you may not, unfortunately. The methotrexate, which by the way is a cancer drug, the methotrexate is used rarely for abortion. It is used more commonly for tubal pregnancies to resolve tubal pregnancies. However, it is rarely used for medical abortions. But unless the woman really listened to what she was taking, she may not know. Hopefully she'll have some paperwork showing what she took. The methotrexate, they have to give her more warnings because since it is an anti-cancer drug, it can cause some side effects that are very different from mifepristone, and they have to be warned about that. So they very likely will be given a piece of paper or be told that this is different from the usual medical abortion. The ones that of which we are aware, where women presented after getting methotrexate to abort, they knew that they had gotten something different and that it was methotrexate.
Now, Dr. Delgado, is there any new protocols out for when the mom is taking both the medications to go ahead and give them the progesterone?
So if a woman has taken both mifepristone and misoprostol, what we recommend is that she first of all have an ultrasound to see if the baby is still alive and in the uterus. And if at that point she understands the risk of birth defects with misoprostol exposure, which increases the birth defect risk to anywhere from 6 to 12% as opposed to 3% in the general population. If she's willing to take that small risk, then we recommend going ahead with the usual progesterone protocol and then monitoring her carefully. But of course, a very, very deliberate, careful, informed consent procedure because she is taking the chance of more birth defects.
I think I've seen some billboards advertising the abortion pill reversal, but I'm wondering if we've ever tried to get any brochures out to the colleges or any radio commercials or anything like that to get word out other than the sidewalk counselors and the few billboards that I've seen.
At Steno Institute, we are fundraising right now with the hopes of having a radio campaign. So that's something that's on our planning board. Up to now, I'm not sure if anybody else has had any radio ads. I am aware of several billboards that have been put up across the country by different organizations. Students for Life has a big outreach where they give out a lot of pamphlets and brochures on college campuses and spread the word about abortion pill reversal. Live Action has been a great proponent of spreading the word about abortion pill reversal, including little video vignettes that are shown on social media and other places online.
Dr. Delgado, there's another chat from Amy Farm. Some insurance cover the cost of abortion. Are you aware of if insurance covers the cost of, any insurances cover the cost of progesterone after the abortion pill, or if there are organizations that help cover the cost of APR?
Usually the insurance will cover the abortion pill reversal treatment because essentially it's the same treatment as you would have for a situation called threatened miscarriage. So we treat it the same way, we bill it the same way. Now, in the past, Medi-Cal, which is the Medicaid in California, of course, has not covered progesterone. So in those cases, if the woman cannot afford to buy the progesterone, local pregnancy help centers have usually come through with paying for the progesterone. If they are unable to do that, then Heartbeat International has a fund for that. In my knowledge, I've never known of any woman not being able to start a reversal because of lack of funding.
And there's another chat from Heidi Willen. Is there a specific gestational age when an abortion affects an Rh negative patient regarding future pregnancies or transfusions? Question, oral progesterone is now preferred over IM?
Okay, so the first part of the question is about Rh sensitization. Just to give a brief overview of that for those who don't know what that is, all of us have blood that's either Rh positive or Rh negative. If you are Rh negative and you get exposed to Rh positive blood, you will develop antibodies. And during pregnancy, it's common for blood to mix. And so that's why we check that during pregnancy. When an abortion occurs or abortion is committed, there's bleeding, and some of the embryo or fetal blood can spill into the maternal circulation. And if the baby is Rh positive and the mom is Rh negative, it could sensitize her. Now, we don't know a gestational age where that doesn't happen and sort of a cutoff where it does happen. We just know that it's an increasing risk as the preborn baby is further along in the pregnancy. So we really don't know. And so that's why it's important that the woman's Rh status be checked and that she'd be given a shot of something called Rogam to protect her if she is Rh negative, because of course we don't know the preborn baby's blood type at that point. Now, abortionists are essentially telling us just ignore that risk. Don't worry about it, because they really aren't concerned about ill effects in future pregnancies. Now, the other question is oral progesterone preferred over IM. The answer to intramuscular injections, I would say yes, it is. For one, in our largest study to date, it was as good or better than injected progesterone. Number two, everybody likes pills more than shots. And number three, injected progesterone is available at a lot of pharmacies, but in the 50 milligrams per ml concentration, which requires a 2 shots for each dose, two shots, 2 milliliters in each side of the bottom. So that's 2 uncomfortable shots. You can get compounded progesterone at 100 milligrams per ml. However, compounding pharmacies are being overly regulated at this point, especially in California. And a lot of compounding pharmacies are no longer compounding injectables, or they're more difficult to obtain, and they will only give you that progesterone if you have a specific patient who's going to receive it. So that means if you have a woman coming in with request for abortion pill reversal, you have to wait for the compounding pharmacy to make up that progesterone. You can't just keep some in the office like you used to do. So it just makes the injected progesterone more complicated. So because of those 3 reasons, oral progesterone is favored now. And oral progesterone should be taken with food because absorption is increased when it's taken with food.
Another chat question from Marcia. At a resource pregnancy center that has only an RN on staff full-time, can the physician leave standing orders to administer oral progesterone for a patient requesting reversal, or does the patient have to be seen by a physician?
As long as there's good physician oversight of the center, then the physician can leave standing orders, and it's probably a good practice for the RN to call the physician to let him know that she's going to implement the standing orders on any particular patient. And then the physician should see that patient face-to-face within 72 hours. So we think that the progesterone can safely be started right away, and then an ultrasound be done as soon as possible, but not to delay the progesterone, and the physician or nurse practitioner or other practitioner visit within 72 hours. We think that's good practice as long as there's very good communication with the patient and that the physician knows about the case.
Can you speak to some of the regulations or concerns of someone taking the second pill as the only pill?
Sure. So in many third world countries where mifepristone is illegal, or where mifepristone is difficult to obtain because it is a very expensive drug, misoprostol abortion has been done for years. And in our country, sometimes it also is done because it's easier to obtain misoprostol and it's less expensive. You can go to the regular pharmacy and get misoprostol because it's approved for gastric ulcers. It's rarely used for that nowadays. It's actually mostly used these days to start labor in certain women or to soften the cervix in certain women to get them ready for labor induction with Pitocin. So the use of misoprostol for abortion is unapproved. It would be considered off-label usage. It's kind of a gray area because there's a lot of medical literature out there supporting the use of misoprostol for medical abortion. So a doctor using misoprostol for abortion would probably be operating within legal limits. However, if there were complications, he or she might get into legal difficulties because the malpractice attorney would argue that, well, you use misoprostol when there's an FDA-approved combination, mifepristone plus misoprostol, that has fewer complications for the woman and has a higher success rate. So that would be the real pitfall that the abortionist would encounter. So I see that I can read the chat. If the 72-hour follow-up is not practical, the medical director is 2 hours away. Is there an alternative protocol for that follow-up visit? Well, I think you could, in a pinch, you could have the medical practitioner do a telehealth visit. Right now, telehealth visits are appropriate and accepted. And that would be a way to do a face-to-face visit with the patient in order to make sure that she fully understands everything. And you would have the patient obtain a blood pressure reading, and you would be able to ask very important questions. After that, though, I would still schedule an in-person visit as soon as possible because you'd want to get an ultrasound and you would want to do a physical examination.
Another chat came in.
Okay.
Can you speak to the breast cancer increase with medical abortions?
Well, we know that with all abortions, the data do support there's an increased risk of breast cancer with abortion. What we don't know is if it's the same with medical abortion as with surgical abortion, because we don't have enough data yet. We think that there is an increased risk with medical abortions because, like I explained, the breast cells have been developing, and during the developmental time during the pregnancy, until about 32 to 34 weeks of pregnancy, the breast cells are in a cancer vulnerable state because they're dividing rapidly and they're very vulnerable to cancer. So if you stop the development right there in that cancer vulnerable state, then you're going to increase your risk of abortion. The other reason why abortion does increase the risk of breast cancer is an indirect reason. That's because we know that with surgical abortions, the cervix is stretched and damaged microscopically, and there's an increased risk of preterm delivery after a surgical abortion. Therefore, and we know that preterm deliveries increase the risk of breast cancer. So there's that indirect, but of course, with the medical abortion, the cervix is not dilated. So we don't know if that also contributes.
Any other questions? Well, thank you again, Dr. Delgado. Again, your website is stenoinstitute.org.
Yes.
Yes. So we can all get more information. Thank you for your pro-life work and your dedication. I'd like to acknowledge the producers of this ATI series, Sister Raquel Recruz, Rosie Erickson, Sister Beth Momberg, and Jacob Barr. And if any of you would like to learn more about the work at International Life Services or the life of Sister Paula Vandegeer, please visit our website at www.internationallifeservices.org. Sister Raquel, I'll turn it back to you.
Well, thank you. It's been a pleasure to have everyone here and being able to see all the people. Thank you again, Dr. Delgado. Thank you, the team that made this possible. And thank you, Jesus, for all of you. Just continue to pray for each of us and continue with this information, hopefully learning information for all of us here. And hopefully next year we'll be able, we're gonna try really hard to make it in person, the ATI. And for all the followers for this year, thank you again. Give you thanks, Jesus, for all this blessings, for all the people that have made this possible, all the people that are really eager to learn more and more to help our people in need. Give us the wisdom and the light to continue with this process. In Jesus' name, amen.